Welcome to episode 2. So we are going to be talking today with Dr. Lauren Roth, and we're going to be talking about serious mental health disorders or serious mental illnesses. And part of the reason we chose this as our second topic is because we know that there are a large number of individuals with serious mental health issues who are involved in the criminal justice system. And we also know that there's sort of an emphasis on them in some portions of the recent legislation, AB 1810, particularly with respect to the funding from the Department of State Hospital. And so we thought that there would be an interest in learning a little bit more about these folks from someone who has a very deep and rich background in understanding these issues. So first I want to present Dr. Roth. She's a forensic psychiatrist who did her undergraduate studies and medical school at Tufts University in Boston. And she did both her psychiatric residency and forensic psychiatry fellowship training at NYU Bellevue Hospital in New York City. She worked at Bellevue treating incarcerated mentally ill men on the Bellevue inpatient forensic unit for her entire career until just this year when she relocated to the West Coast to San Francisco to become the medical director of jail behavioral health services at the San Francisco County Jail. And she's also a faculty member in the Department of Psychiatry at UCSF. And so that gives you a sense of how deep her knowledge is in these topics. And with that, I will pass it to Dr. Roth to explain what our objectives are today.
Well, thank you for having me. I just wanted to say one more thing about my background in arriving here. So prior to, I'm pretty new to California, as you heard, and prior to that, the jail in San Francisco had psychiatry staffed by a nonprofit, and as of recently, UCSF has basically formed an affiliation with the jail such that the psychiatrists at the jail are faculty members, and it is becoming a training environment for training new doctors. So just thought I'd add that. But again, thank you for having me. So wanted to start with the objectives for today's talk. So in today's talk, I hope to review definitions of serious mental illness, review some of the most common serious mental illnesses and treatments, review some treatments for the common serious mental illnesses, and also to review some other comorbid conditions and illnesses that you may have experience with or see. So it turns out that there isn't really one standard definition for serious mental illness. And so what I wanted to do is present a couple. And they have similarities. One that I came across is from the New York State Office of Mental Health. And according to that office, a serious mental illness is a DSM-IV diagnosis other than substance use disorders, organic brain syndromes, developmental disabilities, or social conditions, plus the individual would need to be getting Social Security, so they would have had to qualify for Social Security. They need to have extended impairment in functioning as it relates to their ADLs, which are activities of daily living, social functioning, et cetera. And they need to have shown that they have sort of a reliance on psychiatric treatment, rehabilitation, and supports. So that's a definition from New York. There is a California law that concerns short-term disability, and that defines serious mental illness as actually a list of specific diagnoses, the first three of which, schizophrenia, schizoaffective, and bipolar, appear on just about every list of major mental illness, of serious mental illness. I will say the last two on the list I don't think appear on every list, anorexia and bulimia. So that surprised me a bit. Those are certainly serious illnesses in anyone's book, but according to this particular jurisdiction, they qualify as serious mental illnesses. And then the SAMHSA definition, SAMHSA is the Substance Abuse and Mental Health Services Association. So that definition is that any time during the past year, the person has a diagnosable mental, behavioral, or emotional disorder. Again, there's some similarities with the other definitions. Causes serious functional impairment, interferes with major life activities. Finally, our final example will be from a definition from the Stepping Up Initiative. Same kind of idea, but again, could be some variation. So a disabling condition, a reliance on treatment, support, and rehabilitation, can affect activities of daily living and, a person's kind of ability to function in society. And then again, the third bullet point includes some examples, which here, schizophrenia, bipolar, et cetera. So you can see that there isn't one definition, but there are generally some similarities. So I wanted to start out with going over some terminology, words and ideas that you've certainly probably heard of, but I just wanted to say a bit about them. So psychosis it's not one symptom. I wanted to make sure people understood that. Psychosis is a broad term used to describe some combination of these symptoms. So a person who's psychotic could have sort of any one or more of these. They could have a break from reality in terms of sort of what their thoughts and beliefs, perceptual disturbances, which is referring to kind of how they perceive the environment around them. So, for example, a hallucination would be when a person perceives sounds that aren't really there. So that's a perceptual disturbance. Psychosis can include disorganized or purposeless behavior or speech patterns, and it can also include negative symptoms, which I'll go into in the next slide. And I just think it's important to point out, psychosis doesn't always mean agitated. I think that some people, maybe who aren't in the field, use the word psychosis kind of in a hand-waving way to mean, oh, he was quite agitated. You can be psychotic and be totally calm and docile. It is certainly not synonymous with agitated. So psychosis can involve positive and or negative symptoms. So positive symptoms are things like hallucinations, hearing things that aren't really there, delusions, which I'll say a bit more about in the next slide. It can also include negative symptoms, which is basically the extreme absence of something. So I think we're familiar with the concept of apathy. Amotivation is someone who sort of lacks motivation to do anything. Anhedonia is the lack of enjoyment. Paucity of thought is the lack of having a lot of thoughts. I mean, again, when I sort of say that may not sound like it's worthy of mental illness, but with schizophrenia, which is the main disorder for which negative symptoms are an issue, it's like a real significant lack of these things. It is profound. There's a profound lack of motivation. There's a profound lack of thought. So that's just kind of a description of negative symptoms. Again, delusion, something you're probably sort of familiar with, at least in the abstract, but the definition is delusions are fixed false beliefs that a person holds even in the face of evidence to the contrary. So you could put that under the category of a break from reality. And, some of the more common ones that I hear about, I would say multiple times a year in my work, would be a patient having the delusion that a chip has been something's been implanted in his or her body that allows his or her thoughts to be broadcast out to the world. I've had patients who believe that there are cameras in the sprinklers in the ceiling or in the TV that monitor them wherever they go. And I've certainly had a bunch of patients who have a delusion that they are Jesus.
And Dr. Roth, just before we move to the next slide, so some of the things that you just described, these delusions are things that are relatively unlikely. Could people have delusions that are less outlandish?
Yeah, I mean, one delusion I've seen that would repeatedly in my career that I think people see, a delusion that one's partner or spouse is having an affair or going off and doing, spouses going off and involved in porn. So remotely within the realm of reality, but as a doctor, as a treatment team, I and my colleagues have determined that this is absolutely not the case and that it is, in fact, a delusion. Okay, so this slide, I just wanted to say a word about chronic versus episodic disorders. So schizophrenia, which of course is a big one we're going to be focusing on in a moment, is a chronic illness. And what that means is that it's basically fair to say that every single day after the person has been diagnosed with schizophrenia, it's somehow in some form or another, it's present. It's chronic. An equivalent would be diabetes, for example. Bipolar disorder is different in that it's episodic. And the person has episodes of mania and perhaps episodes of depression. But in the inter-episodic periods, if the person, is doing quite well, maybe hopefully taking medication, they might function totally normally, where there's really actually perhaps no indication whatsoever that they have an illness. And so the illness is only sort of contained in the episodes. I also wanted to give a caveat about drug use disorders, which we're not going to cover in detail today. In the past, in the prior DSM, we called it let's say cocaine. We would call it cocaine abuse or cocaine dependence. In the current DSM, the terminology is a cocaine use disorder. Drug use complicates diagnosis of mental illness to an enormous degree, and there's just no solution for that. Intoxication with a variety of drugs and alcohol can mimic psychosis. It can mimic mania. It can even mimic negative symptoms. So even after intoxication clears, even if after someone, say, hasn't used in a few days, or substances can still cause ongoing psychiatric symptoms for days, weeks, or even months, and sometimes even longer. So accurate diagnosis is difficult, if not impossible, during periods of active drug use. And yeah, I mean, I sort of wish we had a solution to that, but it's very difficult. So now I wanted to focus on schizophrenia in particular, and I wanted to start by just saying a word about how schizophrenia is diagnosed. So in order to have a diagnosis of schizophrenia, the person has to have 2 out of these 5 for a significant period of time within 1 month. Delusions, hallucinations, disorganized speech, disorganized behavior, or catatonia, negative symptoms. So catatonia is sort of taking negative symptoms to even further extreme, where a person who's catatonic might not even speak or move for hours, if not days on end. It's considered pretty much an emergency. So those 2 out of the 5 of those are required for a diagnosis. In addition, there's more that's required for the diagnosis. Namely, there needs to be a period of time which we refer to as a prodrome that lasts 6 months or more, in which the person disengages from social activities, maybe shows a change in personality or is more isolative, maybe they're irritable or depressed, and maybe some subtle psychosis symptoms are emerging, maybe. It's sort of hard to recognize a prodrome when it's happening. I mean, it might sound just like a grouchy teenager, for example, who just doesn't want to spend time with the family. I would say it's sometimes you don't really recognize a prodrome until later, and then you look back and say, oh yeah, there was that period last summer when he wasn't talking to anyone and he stopped hanging out with his friends and so forth. So you sort of put it in perspective with the whole diagnosis. But that is required for the diagnosis. And then finally, at the bottom of the slide, there just needs to be a significant impairment in functioning in order for the diagnosis to be made. Everything that we've said here under diagnosis, it needs to be serious, and only then do you get the diagnosis of schizophrenia. So antipsychotic medications are the medication treatments we use for schizophrenia. So some examples you might have heard of: Haldol, Risperdal, Zyprexa, Abilify. There's probably another 5 or so more, but those are some of the more common ones. So responses vary. Some patients are quite treatment refractory, which just means that it's hard to find the medication that truly addresses their symptoms, and you just might end up going from one to the next in an effort to find the one that helps that patient, while some patients respond quite well and sort of try one medication and get significant improvement in their symptoms. I will say that most medications do not robustly address negative symptoms or the cognitive impairment that can occur over the long term with schizophrenia. It's sort of hard to give someone motivation and those sorts of things that I mentioned under the negative symptom slide when they don't have it. Medications primarily help with hallucinations and delusions. Although I would say that's not across the board. I would just say it's generally that's the case. So side effects from antipsychotics are a big deal, and they really get in the way of a patient's sort of willingness to stay on the medication. Weight gain is probably weight gain and sedation, sleepiness are probably the most common ones. Certain medications can cause elevated blood sugar, which if left sort of ignored for months or years on end could lead to diabetes. So that can be quite serious, obviously. Can cause elevated cholesterol, which if left ignored for many years on end could lead to heart disease. Some of the medications have as a side effect the same kind of damage on the brain that Parkinson's disease causes. So what you might find is that people on certain medications actually look like if you know anyone who has Parkinson's, there's a certain way they sort of look. Some people on psych meds look that way. So what that is a sort of blunted or blank appearing affect, moving sort of more slowly, not quite with the fluidity of movement that the rest of us have, and it might involve a tremor or other involuntary movements. And in general, some, not all, but some side effects can be permanent if left unaddressed. Despite how bad that all sounds, there's certainly improvement as compared with the medications that we had, say 40 or 50 years ago, but they're still pretty tough to take for some people. So not everything treatment-wise is medication. There are non-pharmacologic interventions that we certainly hope to give to as many patients as possible, and that could be involvement with the patient's family in some sort of family therapy, psychoeducation group therapies, so that is sort of, education groups to teach patients about their mental illness, how to recognize symptoms and so forth. socialization, life skills. That's just kind of helping schizophrenic patients with some of the just kind of usual life stuff that may be hard for them, interacting in public and so forth. These interventions are felt to be especially important for first break individuals who have just been diagnosed with schizophrenia, because research has shown that if you kind of tackle the illness thoroughly and early, the person might fare better in the long term. And then case management, of course, is an important part of the treatment for people with schizophrenia. I think a case manager might be someone who reminds a patient who has poor insight about how important it is to make it to their doctor's appointments, about how important it is to make it to their parole or probation. They will help with that. They'll help coordinate. And then, as another example, maybe someone who has more negative symptoms, who sort of never leaves the house. Maybe a case manager would be someone that ends up helping the patient get out and get to those appointments and kind of help motivate. And I'll also say that maintaining sobriety for individuals who use drugs and alcohol is obviously also an important part of the treatment of schizophrenia and kind of managing that disease. So I wanted to list a few other things that you might see with schizophrenia that kind of don't fall under the official list of symptoms, but things that you'll notice. So people with schizophrenia often have a very concrete thought process, and they have difficulty with abstract thinking. And this can actually be kind of frustrating if you're trying to have a conversation with them or speak to them or ask them a question that involves some kind of abstract or nuance, because they will just perhaps answer you with no sense of abstraction or nuance, and it can actually be kind of frustrating, and you have to kind of remind yourself, oh, this person's not capable of that. So even something as simple as if-then statements, cause and effect statements, that might be hard for some of them because their thought process is so concrete. And along the same lines, cognitive impairment. So cognitive impairment is something that happens over the years that a person has schizophrenia, and they just function at a lower level cognitively. Poor insight, it's a big issue with people with schizophrenia. I mean, they just may not believe they're mentally ill. If they truly believe that there's been a chip implanted in their body that broadcasts their thoughts out to other people, that's a reality to them. They don't see that as an illness. That's a reality. So it's very hard to tell that person, oh, no, that thing you believe, that's a sign that you're ill. A blunted affect, that's kind of what I referred to before. And negative symptoms, as I also said, it could be, in a way, it could be a side effect of medication. So that's something you'll see. They just kind of don't have the normal facial expressions that the rest of us have, or the kind of respond to the same social cues facially that you and I would kind of respond to and have. They might have a bit of a childlike demeanor, again, kind of going along with having a concrete thought process and being cognitively impaired, so maybe functioning at the level of a 10-year-old or something. They might sort of come across in a vague sense a bit like a child. And finally, being internally preoccupied is when someone appears distracted by or is responding to hallucinations. So if you think about just the phrase preoccupied, I mean, you might be preoccupied with all these repairs that I need to do on my car. That would be, regular preoccupation. Internal preoccupation would be someone who is distracted by something that's not actually there. Talking about what causes schizophrenia is a bit beyond the scope of this talk, but I will say that it is complex interactions between genes and environment, that heredity can play a role, but it is not the only determinant. And similarly, trauma and other stressors like drug and alcohol use can play a role, but it is by no means the cause of schizophrenia. So what are useful strategies for poor insight? So I believe this is a question that might have come in at some point. So it's really hard to just convince someone they have an illness when they don't think they have it. But one of the things I do, and it really isn't particularly successful, but it's just a strategy I use, is I sort of pose a neutral question or a statement of observation to the patient, the answer of which would ideally be an unavoidable admission that there is evidence of illness present, although sadly that usually is not the patient's answer. But it's still kind of the way I might try to go about things. So an example of that. So, Mr. Chen, I hear you saying that you don't believe you have a mental illness, but I noticed that various doctors at 4 different hospitals have found you ill enough to require hospital admission. What do you make of that? So I'm sort of, as you can see, I'm sort of posing an observation and then just asking this broad question to the patient. I want the patient to come to his own conclusion. Again, he probably doesn't, but I hope he does. And another example, Mr. Johnson, you say that you feel productive and invigorated when you're off of your mood stabilizer, but it must be difficult to enjoy that when you keep ending up in hospitals and in jail, no? So again, I would hope the individual would say, oh, you're right, but that's not always the case. And again, just kind of saying a word then in general about talking to patients. In my years of sort of training to become a psychiatrist, psychotherapist, I do feel like the best approach and the approach that I utilize is to remember that patients have dignity, that they deserve some degree of autonomy, that they deal with a great deal of stigma having a mental illness. They are frequently talked down to, and other people tell them what's right for them. And so I need to remember that I need to have some humility and sort of remember that I'm not all-knowing. And so I keep that in mind as I speak to patients. And again, I hope that the patient comes to his or her own conclusions as much as possible. So wanted to move on to bipolar disorder. So as I mentioned, bipolar disorder is an episodic illness that involves one or more manic episodes. It turns out you don't actually have to have a depressive episode in order to get bipolar disorder diagnosis. You just have to have had one or more manic episodes. And so mania is a state that lasts several days to a week or more in length that involves a decreased need for sleep without being tired, racing thoughts, moving from one thought to the next very quickly, pressured speech, which is speech that is both rapid and very difficult to interrupt, distractibility, the person gets distracted frequently. It can involve grandiose ideas like a belief that someone has special powers or extraordinary capabilities. And it can include risk-taking behavior uncharacteristic for the individual. So spending more money than usual, an uncharacteristic increase in sex, and driving recklessly. And then similar to with schizophrenia, I wanted to give a slide with a few other examples that maybe don't make it onto the official list of symptoms, but that you might also see. So poor boundaries. I think people with mania, physically, they might sort of have poor boundaries physically in terms of where they stand close to you. They might treat you as though they know you quite well when they don't. Hypergraphia is writing excessive amounts, just thousands of words a day or something, just thoughts, poetry, ideas for future businesses. I see a lot of manic patients who sort of walk around all day and all night without a break and end up with sores on their legs and feet. I see patients with mania who make plans to start several businesses. And you also see people sort of with excessively rude or inappropriate behavior that is uncharacteristic for the person to speak of or do otherwise. So you might see racist comments, anti-Semitic, homophobic comments that it doesn't seem that the person sort of regularly or ever does when they're not manic. So the medication for bipolar is required long-term. It is required even when the person is not having an episode, because the idea of the medication is that it actually prevents an episode from happening. And when an episode does happen, its purpose is then to treat that particular episode. Most medication that's used for schizophrenia is also used to treat mania. And then there is another class of medications called mood stabilizers, which are also used, like lithium and Depakote. And then similar to schizophrenia, some treatments are effective and some are not. I wanted to bring up a couple other disorders. So schizoaffective disorder is also probably almost always going to be on the list of serious mental illnesses. It includes both the chronic positive and negative symptoms of schizophrenia with superimposed manic episodes on top of that. So it's kind of got both. And the treatments are, and everything else, the treatments are very similar to schizophrenia. And the impairment is similar as well. So I wanted to say a word about personality disorders. They're generally not listed under serious mental illnesses. I'm not sure, how much people sort of understand the concept of personality disorders, but basically they are long-term patterns of inner experiences and behaviors that are unhealthy and inflexible and make it difficult for the person to function well in all spheres of life. And because we're talking about someone's personality, we talk about traits rather than symptoms. So a person might have certain traits. A person needs to have certain traits in order to have a diagnosis of personality disorder, and we don't refer to them as symptoms. And I think, again, without going into detail in this presentation, I just wanted to say that just because someone is sort of very difficult to deal with and seems to have a lot of impairment of some sort or problems with their mental health doesn't actually necessarily mean they have a serious mental illness, but it could mean that they have a serious personality disorder. So we have a few questions that were already submitted, and then so we'll address those first. So one question that was submitted was, I hear the word self-medicate a lot. So I think that's fair to say that that's a lay term that is used to describe, why an individual, either seriously mentally ill or not, might be using drugs or alcohol. And I think another way that I guess I would think about that is it's another word for avoidance. I mean, I think a person, for example, with post-traumatic stress disorder, a person who has hallucinations, a person who experiences a whole lot of rage for various reasons might just want to avoid all that. And drugs and alcohol certainly allow someone to escape and to sort of avoid temporarily. Another question we got, what effect does incarceration have on mental illness? Well, it depends. I mean, for the lowest functioning members of society who are homeless, who have trouble getting food, shelter, who are so mentally ill that maybe they have trouble forming full sentences, for those individuals it can be helpful. They have a chance to see a clinician, a nurse, a doctor, they get food and shelter. But for anyone that's kind of higher functioning, and for anyone who kind of usually relies on friends and structure of life, job, and so forth, of course it can be certainly destabilizing for them to be incarcerated.
And Dr. Roth, just to follow up on what you were saying about, for the individuals that it can be helpful, is that also sort of a reflection on the lack of social services that are provided in the community for some individuals?
Well, yeah, absolutely. I mean, it's a sad statement when, for some people, for various reasons, the only care they've gotten, say, in the last year is when they end up incarcerated. What does that say about what's going on in our communities and the lack that exists in our communities? Absolutely, yeah. So, yeah, the last pre-submitted question we're going to go over is, in what ways can mental illness contribute to commission of a crime as it relates to AB 1810? So I certainly don't know a ton about AB 1810, but I can certainly say a few words about it. So my understanding is that it requires a court finding that the defendant's mental disorder played a significant role in the commission of the charged offense. So I guess my comments are that it can certainly be intimately related, or it could be not at all related. And I think it could be extremely difficult to determine either way, or it can be. I mean, a couple examples I guess I was going to give that I can think of in my career in New York. So I had a patient who had mania, was manic, and was out in the streets of New York and was sort of agitated and loud and making a big scene and hyperactive. And he broke the window of a storefront, and he was charged with criminal mischief for that. And then sort of, I think immediately after the arrest, he got brought to the hospital, and we treated him there. It seems to me quite fair to say that the mania played a role in the behavior that led to the window being broken. To me, that seems like it played a role. I had another patient who was a very law-abiding citizen who got schizophrenia, young man, and in a very decompensated state he was very disorganized, he sort of wasn't making sense, he was wandering around aimlessly, he was not taking care of eating, he was wandering away from home, and he wandered into a stranger's apartment, and he picked something up that it seemed he had no purpose to have, and then he walked out, and he was charged with burglary for that. And then almost immediately after the arrest, he was taken to the hospital, and we saw him in that state. Again, I think to me, it seems quite clear that his schizophrenia symptoms of disorganization led him to engage in a kind of behavior which he was then, charged with for a crime. So those are a couple examples.
So then we've gotten a bunch more questions during your talk already, so I'll kind of go through those in order. So one question we got was, if a person has a break from reality while not on medications, but does not have a break from reality when taking medications, does the diagnosis change? No, I mean, I think this scenario sounds to me like the medications were working. I think if a person gets on medication and then their sort of grasp of reality improves, it suggests to me that the medication did what it's supposed to do. That alone would certainly not make me change my diagnosis. It may change their ability to function well, but not the diagnosis. Okay, so then this is a question, I think, about a specific slide where you listed cognitive impairment as a possible symptom for someone with schizophrenia, and the person was asking whether that's inevitable or only if they were not medication compliant or not taking medication. That is a good question. I am almost certain that schizophrenia alone, even if the person has really good med compliance, that schizophrenia alone can cause cognitive impairment over the years. So
I mean, everything's even worse if the person doesn't take meds. But yes, even if the person had sort of impeccable medication compliance, I believe it's pretty likely that over time they'd suffer cognitively.
Another question, again, about schizophrenia, because that was the beginning portion of the slide. Someone asked, given that medication doesn't reduce the negative symptoms of schizophrenia, is there something else that explains why people who go from treatment in jail to treatment in the community seem to wake up and become much more interactive and responsive over time after their release?
So first of all, I haven't treated people in the community much at all in my career. I mostly treat incarcerated people, but honestly, I don't think there's much else to explain that except to say that jail is an extremely difficult place where you probably try to keep your head low and you try to keep to yourself and you try to watch what you say and do. And if someone wakes up, quote unquote, when they leave, it might be because they feel safer. So no, from a psychiatry standpoint, there's nothing else I could come up with to explain that.
Would it also be, I mean, you were referring earlier in the slide about how jail impacts that if people have access to things that they're passionate about or their social networks, that might also help with that motivation because you're able to engage in things that you aren't able to engage in jail?
Yeah, absolutely. I think that absolutely could play a role as well.
We had a question about how a psychiatrist or other qualified mental health expert makes a diagnosis, sort of what that process looks like. Maybe you could talk us through that.
I think that making a diagnosis is both an art and a science. So there's certainly the science of sort of knowing what diagnostic criteria are and having studied what they look like. But there's also really an art. I mean, I think there's an art to sort of asking someone the kinds of questions that elicit the kind of answers that allow you to learn about the person in the way you need to make a diagnosis. So yeah, I believe in terms of where I am in my sort of career right now that there are elements of both science, sort of facts, objective data, and then there's a certain art to it as well.
And I guess to follow up on that question, is it something where you could just have a quick screening tool, quick checklist that could give you a final diagnosis?
Usually not. I mean, there for something like depression, I mean, there's certainly actually very useful screening tools for depression. For schizophrenia, there can be as well, but I think there's more art involved. And I do think that you certainly couldn't say across the board that you could rely just on questionnaires to do the kind of diagnosing that I do.
It's more complicated than that.
Yeah.
Okay. Then I had a question about how you determine if someone needs residential as opposed to outpatient treatment, and whether most people with serious mental health disorders require residential treatment.
It's a little bit hard for me to answer this because this is often not an MD who does the kind of discharge planning involved in this. Do most people with a serious mental health disorder require residential treatment? I mean, most is kind of a fuzzy word. I mean, I certainly think that people who have families, people who maybe, sort of functioned okay before they got the illness, they had a involved family, maybe they even had a job or a support network, they might not need residential treatment. People who didn't come from a lot to begin with, didn't have a lot of resources to begin with, and have a serious illness that is refractory to treatment, that's going to be someone who is more likely to. So it's kind of hard to say across the board.
And following up on that question, could it also be fluid, whereas someone may need residential for some period of time, but not?
Oh, absolutely. I mean, I think when someone is sort of recovering from a particularly bad episode of sort of a bad period with their schizophrenia, they might need a cushion before they return home, say, so they might need some residential treatment. So it looks like another question we got. Can a person with narcissistic personality disorder willingly control it or bring it into check? In other words, can they help it, or are they destined to be narcissistic? No, I mean, I don't think you can will what your personality is and what your personality traits are. What you can do is you could be in therapy. And for the sort of more common personality disorders, which are antisocial is like really hard to treat, but borderline personality disorder, and yes, narcissistic personality disorder, an individual like that, if they were motivated if they saw that there was a problem, if they saw that their personality was getting them into trouble, and they wanted to engage in therapy, I think that's kind of the treatment of choice. But again, I don't think they can just help it. No, I think that that's their personality, and they have to work hard to try to help it.
So we got another question about bipolar disorder and whether the diagnosis can be made merely on episodic depressive behavior with no manic episodes.
No. The person needs to have had a manic episode. Maybe you've seen it, maybe another doctor saw it 5 years ago, but some point in their life they need to have had a manic episode in order to have bipolar disorder.
And then we got another question about whether you find that defendants sometimes mask illnesses and why someone might do that.
So there's a variety of reasons why someone might not want their mental illness to be out there. A, they don't believe they have one, and so they just, if they do have some weird thoughts that maybe they know, cause people to raise eyebrows, they may kind of keep quiet on those. They don't want to advertise the fact that they're different. Another thing is mental illness can be very stigmatizing within the jail. Some jails have separate housing for people with mental illness. I suspect that some very small jails maybe don't. They just don't have the resources for that. And so it can be very stigmatizing. And so a person would, in general, it's stigmatizing. And so a person might want to kind of mask the whole idea that they are, different, ill, symptomatic, et cetera.
I got a question that I assume is from someone who works in a court. When I'm interacting with someone who's showing symptoms of a mental disorder in court, what's the best way to calm them down so that we can help them? Any tips for dealing with someone who's in a state like that in the court situation?
Well, first of all, it sounds like you're talking, when you say symptoms of mental disorder, it sounds like you're talking about agitation symptoms as opposed to quiet symptoms. So, because as I said, I think not all symptoms require calming down. Wow, that's a whole training. That's a whole topic of how do you de-escalation techniques. I would certainly encourage people to Google de-escalation techniques or talk to your local colleagues about training on de-escalation. I think listening, doing a lot of listening, not talking over them. I think watching your own affect. I think it can be very easy to raise your own voice and to sort of talk like this, to try to, quiet someone down. You want to try to bring your voice down a notch. You want to talk very quietly. You want to talk more slowly than usual. You want to empower the person, make them feel like they're being heard. So those are just first look at what some de-escalation techniques are.
And then we got another question about how effective non-drug interventions are in treating schizophrenia.
They should not be used alone. If that was your question, are they effective in conjunction with medication? They can be. Again, to be honest, I see a very low-functioning segment of society who tends to be homeless and doesn't have families. If a patient has a family, has a support network, has maybe other friends who have the illness as well, and can derive support and meaning, in their life and so forth, I think they can be very effective. It's just that, sadly, in our, population of incarcerated individuals, it's going to be, it's hard to see that. But yes, I think, there are programs around the country that help people with schizophrenia feel very productive, feel very, motivated to take care of themselves, to interact well with family and so forth. So yes, it can certainly happen and should be happening in conjunction with medication treatment with a psychiatrist.
So we got a question, I think, based on one of your last comments, Dr. Roth, about why antisocial personality disorder is so hard to treat.
I think, but the very nature of someone who's antisocial, who truly meets criteria for the disorder, is that they don't think they have a problem. They deceive people. They don't care about other people's feelings. They manipulate people for their own good. They're living life just fine. They don't see this as a problem. So to get that person to try to change, whereas, for example, with borderline personality disorder, maybe an individual ends up in psych wards a lot, maybe they're cutting themselves, maybe they have suicide attempts, you might be able to engage that person, say, look, you seem like you're suffering, maybe that person's going to show some motivation to work on themselves. But someone who's antisocial, they kind of think they're just fine as is, and life is working out just fine as they manipulate and deceive people and break laws. And so, yeah, I think it's hard to even get through to them.
So we have one more last question. So this was, how does schizophrenia work, and why does medication help? I think that may be a large topic, but if you could take your best swing at that one.
How does it work? There are certain areas of the brain that are diseased, basically, that aren't working correctly, that cause things like for you to hear things that aren't really there and for you to believe things that aren't really true. I mean, that question's a bit too big for me to answer, but it is, there is actually something kind of identifiable in the brain that is going on, that's an imbalance or a disease process. Why does medication help? Because the medication actually addresses that area of the brain. Unfortunately, the medications are quote-unquote messy in that they affect other areas of the brain, and that's why you get things like side effects, unintended effects of the medication. But medication helps because it targets the parts of the brain that are disordered in these people.
So I think with that, we're going to close questions and move on to the last couple of slides. So we just wanted to remind people of some resources. The webinar is going to be posted on the Judicial Council YouTube channel. I wrote by 2 weeks from today, but Octavio said by early January, so I'll defer to him because he's going to do the hard work of editing and posting it. We also wanted to announce that this morning we went live with a Behavioral Health Education Series webpage, and so the link is on this slide. This won't be in the slides that were distributed yesterday because we did not yet have the web page, but if you take a screenshot of this page, you can access our Behavioral Health Education website, and that has both some general resources from different government and nonprofit organizations about mental health courts and drug courts, and also has the links to the most recent webinar that we aired in November on AB 1810 implementation. And once we do get this webinar edited and ready to be on YouTube, it will also contain the link to this presentation that you've just watched. We also wanted to remind people that there's a mental health listserv that Arlie is the moderator. She was one of our presenters last webinar, and you can email her if you want to be added to that. And I know there were some questions about sort of strategies to engage people in court, and I know that there were some useful conversations on the mental health listserv a few months ago where judges sort of talked about different resources that they found helpful, books that they had read that gave them some useful information. So that's a wider audience to engage in terms of getting resources. And then finally, if you have additional questions based on the webinar, you can also email us and we will endeavor to respond to those. We apologize that last webinar there were, I think, 2 questions that we were not able to respond to because we had a tech glitch during the presentation last time, which hopefully you didn't notice, but it meant that we didn't know the author of 2 of the questions. So if you were one of the authors of those questions and you did not have your question answered, please email it to us. We did, for the ones that we were able to find out the author, follow up. So those are some of the resources. And then we also wanted to announce that we have determined a date for the next webinar, which will be February 7th of next year, 2019, at the same time, a Thursday, 12:15 to 1:15. And that webinar will be about working with county behavioral health. And that's primarily because we know that that presents a challenge, and a lot of people know that they are directed to work with county behavioral health in the collaborative court context and also in the context of AB 1810 because that is most often the treatment provider for justice-involved folks with mental health issues. But we wanted to have a little bit of guidance about how to navigate working with county behavioral health, who they are, what the different treatment options are, and some of the red tape that makes it harder to access certain services than others. So hopefully we'll have a good speaker lined up by February 7th, and we'll be able to share that information with you. We want to thank everyone for joining us today, including Dr. Roth, who volunteered her time and spent many hours on the phone with us in advance of this presentation preparing. So we wanted to thank her for sharing her expertise and thank everyone who participated today for attending and also for emailing in questions. With that, I think we're ending 1 minute early. So thank you again and have a good rest of your day.